Thank you very much, Professor Jibrin. Now we will move on to the second speaker, Professor Remo Panaccine. He is the Director of Inflammatory Bowel Disease Clinic and the Director of GI Research and Professor of Medicine, University of Calgary. Welcome, Professor Remo. And he will talk about post-IBD patient preventing pouchitis and recurrence.
Just get these loaded up. So thank you again for having me, and we'll talk about again another big problem I think in the management of inflammatory bowel disease, which is the post-op management, because for many years we had limited options or options that really didn't serve our purpose. One of the important things I think in the post-op management of inflammatory bowel disease, and especially in post-op recurrence, is a process issue. So what we often see is the fact that once we send the patients to the surgeons, many times those patients don't return for their post-op management as far as either having medication started or post-op right there. Thank you. Or their evaluations. So I'm going to encourage you that you should, again, adhere to strict timelines when it comes to sending patients to surgery and having them come back. And certainly in our unit, we like to see the patients back within the first 2 to 4 weeks. So what I'm going to talk about is I'll go over briefly the risk of relapse. I'll talk about post-operative management options. And I was asked to speak about pouchitis as well, and I'll talk about this briefly in 20 minutes. Each one of these talks is probably 30 minutes long, so I'll leave pouchitis to the end if I have time. So what's the risk of relapse? Most of you are familiar with this data from Paul Rickert's, which clearly outline that we have a problem of post-operative recurrence. The highlights of this study are not the fact that we have high rates of post-operative recurrence, but the fact that there's a huge disconnect between when we have endoscopic recurrence, which you can see, and the symptomatic recurrence. So the first take-home message is we don't wait for symptomatic recurrence in these patients. You want to assess them for post-operative recurrence endoscopically, and you need to have a monitoring or a process method to ensure that that happens. Because many times if you wait for the symptomatic recurrence may happen 3 to 5 years after the endoscopic recurrence, and depending on the patient's phenotype, many times when they present back to the clinic with symptoms, they've already had complicated disease. So it's not much different than what I spoke about yesterday. It's about monitoring post-operatively. If you look at newer data, this is a review by Laurent Perrin-Burlet's group. You can see that the clinical and there is that disconnect between clinical recurrence, which is only about 26% at a year, versus endoscopic recurrence, which sits anywhere between 50 and 75%. It's also important to know what are the risk factors for post-operative recurrence in Crohn's disease. That way you can counsel your patients. So surgery is not necessarily a failure, but once that chapter is being written in the book, you don't want to read that chapter once again. So again, in the same paper, this is a very nice review looking at the different risk factors, with the big ones being active smokers obviously have a higher risk. Established predictors include penetrating disease, the presence of perianal disease. If you've had one resection, you're more likely to have another resection, and extensive small bowel disease. The things that don't play a role are the type of surgery that you've had, the surgical procedure, whether you have small or large resection margins, the location or duration of the disease, the gender, and or genetic predictors. So these are the ones that we're going to really focus on, are the active smokers with penetrating or perianal disease, and the ones that have previous surgery. The other thing that's very, very important is to become very familiar with the Rickert's postoperative scoring system. This ranges from I0 to I3, and it's correlated with your risk of symptomatic recurrence. And so if we're doing endoscopy, it's important because this is when you're going to make decisions. If I'm not going to quiz you on the different appearances of the different Rickert score, but I can tell you, as doing a project right now as a central reader, is that most community gastroenterologists know the score, they just don't know what the appearance is for each score. So you can see if you had an I0 or I1, the chance that you're going to have a symptomatic recurrence is very low, but as you continue to go up the scoring system all the way to an I3, many of these patients will have a prompt symptomatic recurrence. And when they did this, sort of looked at the risk factors for symptomatic recurrence, it was that endoscopic activity, which was the single independent factor that was associated with symptomatic recurrence. So now let's transition into what your management options may be in those patients once you've decided that they may need either primary and or secondary prophylaxis. The number one thing that we can do, and is probably the intervention that we use the least, is sort of smoking cessation. As mentioned in the previous slide, smoking is a significant risk factor with recurrence. It's worse in small bowel disease and in females, so there seems to be an interaction at that level. And you can see that the 5-year and 10-year recurrence is 36% and 70%, almost doubling the recurrence rates compared to the non-smoker patient population. So certainly smoking cessation and a smoking cessation platform should be one of the cornerstones of preventing postoperative recurrence. This is a very nice meta-analysis that was done in the International Journal of Colorectal Surgery, and you can see that smoking increases the risk about twofold, as I had just shown you. So once again, smoking cessation is very important, and you need to decide in your own practice and in your own unit what type of smoking cessation programs you can make available to these patients. Usually, in our unit, if we try to start these interventions approximately 4 weeks to 6 weeks after the surgery, if possible, and we have a whole suite of services that we offer to the patients. So as far as medical therapy is concerned, once we've sort of established that we want to have these patients quit smoking, this is the shopping list, which I'll go over some of these. So the first one is to do nothing, to do no therapy. This is really for gastroenterologists who just like to see what happens, and I would advise you not to do this because you will have a missed opportunity. Waiting and seeing is not what you want to be doing in 2006, because really that translates into wait and don't see. There are some patients who will get away with no therapy, especially the sort of patients who've had sort of 10 to 15 years of disease. It's been mild. They present late with a stricture, and if you do their endoscopy at 6 to 12 months, they don't really have significant endoscopic recurrence. But the problem is we can't accurately predict those patients who will not need therapy. How about postoperative therapy? This is really a story of nothing to lose but nothing to gain. So these are safe medications, but if you look at sort of clinical recurrence rates at 12 months, you can see that in this meta-analysis that it sort of slightly flavors 5-ASA. But remember, the goal is not symptomatic recurrence, it's really endoscopic recurrence, and certainly 5-ASAs by themselves cannot successfully prevent postoperative endoscopic recurrence. How about antibiotics? Again, antibiotics are very good if you can take them. The issue ends up being tolerability. This is looking at some older and newer studies, and if you look at this, the sort of top and bottom panels are reversed. So in the top panel here, what you can see is favoring the antibiotic for clinical recurrence at 12 months when you're looking at metronidazole, and then in the bottom you have one of the new imidazole antibiotics. And once again, these are probably the biggest odds ratios or risk ratio reductions that we can see for postoperative recurrence. So thiopurines, certainly we're moving in the right direction. Clinical recurrence can be prevented with thiopurines. This is looking at the two big trials in a meta-analysis. And then obviously, you can also prevent severe endoscopic recurrence. Where is there no data? There's no data for steroids, budesonide, probiotics, fish oil, or enteral nutrition. So none of these work in preventing postoperative recurrence. Several years ago, Miguel Reguero from the University of Pittsburgh published this series of patients, which got us very excited as we were sort of solidly in the era of anti-TNF. These were 24 patients who were undergoing an ileocolonic resection who were randomized to either continue or receive infliximab 5 milligrams per kilo versus placebo, and the primary endpoint was endoscopic recurrence at 1 year, and they also looked at clinical recurrence and remission at a year as well as histological recurrence. They came out with these very impressive numbers. You can see for the endoscopic endpoints of remission, over 90% of the patients randomized to infliximab were in endoscopic remission at the end of a year compared to only 9% in placebo. And then if you looked within that group of what type of endoscopic recurrence they had, most of the patients who were in infliximab, again, had I0 or no recurrence, and the ones that had recurrence had very little in the way of endoscopic recurrence. So this led to a series of randomized clinical trials utilizing anti-TNF, which I'll review at this point. The first one is the POKER study using adalimumab for postoperative recurrence. Now, this is not a straight adalimumab versus placebo trial. This is more of a postoperative management trial than a drug trial. But it did give us sort of some insights into the efficacy of anti-TNF post-op. So Michael Kam and his group did a very, very good job of putting together the pieces of the puzzle that I already talked about. We know that there's risk factors for postoperative recurrence, which is variable. We know that the patient's and disease characteristics may predict outcome. We know that if you do a colonoscopy at 6 months or 12 months, that the mucosal inflammation per Rutgers scores will predict outcome. We know that postoperative antibiotics can reduce the risk of relapse, as well as thiopurines, and postoperative anti-TNF can do the same. So how do we put all of these pieces of the puzzle together? And that's what Michael tried to do. So POKER took patients who had a curative surgical resection and then risk stratified them into either a high-risk patient population or a low-risk patient population. High risk was considered smokers, those that had a second operation, or perforating disease, as I showed you earlier. Then the patients were randomized. All patients would receive metronidazole because the evidence is there for postoperative antibiotics. The low-risk patients didn't receive any further treatment. If you were a high-risk patient, you would go on a thiopurine, and if you were intolerant to the thiopurine, you would go on adalimumab. The randomization was at the level of the strategy. So 1/3 of the patients were then randomized to no endoscopy. I'm not going to look. I'm just going to see you 18 months down the road and do a colonoscopy. The other 2/3 of the patients were randomized to an early endoscopic arm where the patients would have a 6-month colonoscopy, and depending on their endoscopic appearance, then their therapy would be stepped up. Obviously, both groups then would have the 18-month ileocolonoscopy, which was the endpoint of endoscopic remission at 18 months, and several secondary endpoints were looked at. So this is, I won't walk you through this, this is just an expanded sort of look at what the patients did in the standard arm. Again, they didn't have any endoscopy. They were either on metronidazole, or if they were high risk, on azathioprine or adalimumab. If you were in the active arm, the key here was that you had a 6-month colonoscopy that directed your treatment, and depending if you had no disease, you would continue on the treatment you were on. If you had moderate disease, which was a Rutgers score of 2 or greater, then you would start, depending on what you were on, you would step up your therapy. So what you can see here is remission and recurrence stratified by Rutgers scores, and the patients in the active care arm, the patients who had their colonoscopy, had less recurrence and at 18 months than the patients who were just waited and didn't have the colonoscopy. If you look at complete mucosal healing, again, you have you had higher mucosal healing, 22% versus 8% in the patients who had the colonoscopy and had their therapy dictated by the colonoscopy. This is where it informs, and what I'm going to show you in the last two slides here is, if you look at those high-risk patients, however, you can see the patients who either were on thiopurines, that you can see that patients on thiopurines continue to have high rates of relapse even at 6 months. And if you look at the adalimumab patients, though, there was low risk of recurrence. And this is really what's driving our practice forward. So if you look directly, you have about a threefold improvement in patients who are on an anti-TNF with Humira compared to patients on thiopurines. This study has also been completed. I have two more slides. This was presented at DDW this year. This was a large randomized controlled trial of infliximab versus placebo to prevent postoperative recurrence. This was a registration level trial which was guided by the FDA. It missed its primary endpoint, which was clinical recurrence, but you can see that in the patients who were randomized to the infliximab arm, that there was less endoscopic recurrence, there was more complete mucosal healing, and there was less severe endoscopic recurrence. So there's some methodological challenges because of the power calculations within this trial, based on some estimates of historical recurrence rates, but certainly I think it also shows that anti-TNF is superior to placebo, even though it didn't meet its primary endpoint of clinical recurrence. So what do I do in my own practice, which is probably what you want to hear? I promote smoking cessation, then I pick an agent. I'll show you how I do that, but I constantly reevaluate the patients. They get fecal calprotectins at 3, 6, 9, and 12 months. They all get a colonoscopy at 6 to 12 months, with or without an ultrasound, and we optimize their therapy as per POCR based on their structural assessment. So you look at the risk of postoperative occurrence with those factors that I showed you. If you have very low risk factors, those patients are on no medications. We scope them at 6 to 12 months. If they have no recurrence, they have another colonoscopy at 1 or 3 years with fecal calprotectins in between. If they have a recurrence, we are going straight to either an immunomodulator or an anti-TNF in the very low risk. If you have low to moderate risk, we start those patients on metronidazole with 6-MP or azathioprine. They get their colonoscopies at 6 to 12 months, and we advance their therapy. In high-risk patients, such as the ones that I showed you in POCR and the patients who are involved in the PREVENT trial, they get upfront anti-TNF, which we start within 2 weeks post-op. They have a colonoscopy at 6 to 12 months. If they have no recurrence, they get a colonoscopy every 1 to 3 years. If they have a recurrence, then we'll optimize their anti-TNF strategy. So if you're taking pictures, this is probably what you want to take the picture of. And then for time, I'm not going to, I'm over time now. I have 1 minute, okay? I'll talk about pouchitis for 2 minutes. So obviously there's this whole concept of ulcerative colitis being a cure for surgery. Unfortunately, that's not the case, because even with the area of iliopouch anal anastomosis, there's significant problems. I'll go to the punchline. The first thing is you need to recognize how to scope an ilioanal pouch. When I first went to Calgary, none of the gastroenterologists had ever scoped a pouch. So I know that that's different, but we need to take ownership of this. You need to know the anatomy and where you are as far as the efferent limb, the afferent limb, the pre-pouch ileum, and the pouch inlet, because that's where problems begin. And you need to know the different endoscopic appearances of pouchitis, Crohn's disease or Crohn's-like disease, ischemia, and infection. They all look different, and it takes cases that you see because there's many faces of different diseases, and pouchitis in particular it can have many different faces. Pouchitis is not the only complication. Unfortunately, your colorectal surgeons, if they're managing the patients, everything that happens with a pouch, they think is pouchitis. This is the differential diagnosis. It's very broad. We have a pouch clinic. It's one of my very favorite things to do because it can be very complicated. But these are all the different things that you need to think about in a pouch that is not functioning properly. And they range from surgical or mechanical problems, inflammatory and infectious, with pouchitis being the most common. You can get functional problems. You can develop dysplasia or neoplasia down the road, and they can lead to systemic and metabolic problems as well. There are risk factors for pouchitis, so you should think about this before and maybe even consider prophylaxing them with either probiotics or antibiotics. That includes patients with extensive ulcerative colitis, backwash ileitis before the surgery. Primary sclerosing cholangitis is very, very big. We prophylax all of those patients. If you do serology or genetics, P-ANCA positive patients and the NOD2 polymorphisms increase your risk. Ex-smokers, similar to ulcerative colitis, the concomitant use of NSAIDs and extraintestinal manifestations. What do? There's a whole spectrum of pouchitis. There's acute pouchitis where they'll have one occurrence. Usually it's typical symptoms of increased frequency of bowel movements, urgency, cramps, and rectal bleeding, may or may not have systemic fever. Those patients usually respond to antibiotics, and you can use a whole host of antibiotics: Cipro, metronidazole, combination, macrolides, clavulin, tetracycline, doxycycline. There's very little in the literature. Most of it is with Cipro and metronidazole. The combination does work better than one alone. Recurrent acute pouchitis means that they're having less than 4 episodes a year and they need recurrent antibiotic therapy. Chronic pouchitis usually means that they're having more than 4 weeks of symptoms and more than 4 episodes. Those patients I just leave on chronic antibiotic therapy, pick 2 antibiotics that they respond to, and rotate them every 2 to 4 weeks. And then remember that some of these patients will have Crohn's or Crohn's-like features, even if you look at the colectomy specimen and it tells you it's ulcerative colitis. These patients do not typically respond to